Welcome to the Deep Dive. You're here to really get a handle on dermatomyositis, and we've got exactly what you need, a focused look at the essentials. Think of this as your sort of streamlined guide, perfect for locking down that knowledge.
Exactly right. We've distilled the key information from the definition right through to potential complications. Our mission really is to make this clear, memorable, just a solid framework for your revision. So yeah, let's dive in.
Okay, great. So let's cut straight to it. Dermatomyositis, what's the core definition we need to know?
Okay, put simply, it's an autoimmune inflammatory myopathy. Let's break that down. Autoimmune, the immune system mistakenly attacks the body's own tissues. There's inflammation involved. And myopathy means it's a muscle disease. But the real key here is the combination. You get muscle weakness and a characteristic skin rash. Inflammation hitting both.
Muscles and skin. Got it.
And actually, a really crucial point right from the start, because of certain associations, we almost always screen for underlying malignancy, cancer, after making a diagnosis.
Wow, okay. That's important to flag early. Now, you sometimes hear about polymyositis. Is that related? Is it just dermatomyositis without the rash?
That's a good way to think about it, broadly speaking, yeah. Polymyositis is also an autoimmune inflammatory myopathy, so it causes muscle weakness. But the main difference, compared to dermatomyositis, is fewer, or sometimes no, obvious skin features. So if dermatomyositis is muscle plus skin, polymyositis is more, focused just on the muscle side.
Right, okay, that clarifies things. So what actually triggers this? Why does the immune system start attacking muscle and skin in dermatomyositis? What's the cause?
Well, the honest answer is, like with many autoimmune conditions, we don't know the exact cause. It's likely complex. The leading theory involves an autoimmune response that's probably set off by something environmental, maybe an infection, maybe something else in someone who's already genetically predisposed.
So a mix of genes and environment.
Exactly, a sort of perfect storm scenario in susceptible individuals.
And you mentioned associations earlier, including malignancy. Can you expand on those links?
Yes. So besides sometimes occurring alongside other connective tissue disorders, the really significant link is with malignancy. And this association seems stronger in older patients. Specifically, ovarian, breast, and lung cancers are mentioned as being more commonly linked. So definitely something to keep in mind clinically.
Right. Are there specific things that make someone more likely to get it? Risk factors?
Yeah, there are a few identified factors. A family history of dermatomyositis suggests that genetic component we talked about. Certain viral infections have been implicated as possible triggers. Exposure to some specific medications might play a role too, though the notes don't list which ones. And having another pre-existing autoimmune disease also seems to increase the risk.
Okay, so zooming in a bit, the immune system is attacking muscle and skin. What's actually happening on a, tissue level?
Yeah.
The pathophysiology?
So the core mechanism is this immune-mediated inflammation. Basically, immune cells mistakenly identify components of muscle fibers and skin cells as foreign. They then initiate an inflammatory attack, which directly damages the muscle tissue, leading to weakness, and causes the changes we see in the skin as the rash. It's like targeted inflammation in those specific tissues.
Okay, that makes sense. Now, clinically, if someone comes in with weak muscles and a rash, what else could be going on? What are the main differential diagnoses?
That's a crucial step, yeah. You need to think broadly. Other autoimmune myopathies, definitely, including polymyositis, which we just discussed. Systemic lupus erythematosus SLE can have muscle and skin features. Systemic sclerosis, too. Then you've got things like drug-induced rashes, maybe even infections causing muscle weakness. It's quite a list.
Is there a way to tell the rash apart, say, from SLE? I think the notes mentioned something specific.
Oh, yes, that's a potentially useful clue, though not foolproof. In SLE, the rash often spares the knuckles but involves the skin over the finger joints, the phalanges themselves. In dermatomyositis, it's often the other way around. The rash, particularly Gottron's papules, is prominent over the knuckles and finger extensor surfaces, but might spare the skin between the joints. So think. SLE rash avoids knuckles. Dermatomyositis rash hits the knuckles. That's a helpful pointer.
That is helpful, like a little memory hook. What about overlap with things like rheumatoid arthritis or Sjogren's?
Yeah, there can definitely be some overlap in symptoms like joint pain, maybe some fatigue. But the key difference with dermatomyositis is usually the degree of muscle weakness. It's typically much more significant and central to the presentation than you'd expect just from associated arthritis. The weakness is often out of proportion.
Right, the muscle weakness really stands out. Okay, pulling back out again, how common is this condition? What's the epidemiology like?
It's considered rare. In the UK, the estimate is somewhere between 1 and 10 cases per million people per year. So definitely not common, but important to recognize when you see it.
Okay, 1 to 10 per million.
Right.
Let's talk about what the patient actually experiences. What are the classic clinical features?
The big two, as we've said, are muscle weakness and the skin rash. The weakness is typically proximal, so affecting muscles closer to the trunk, like the shoulders and hips. This makes things like getting out of a chair, climbing stairs, or even lifting your arms above your head difficult.
Like brushing your hair, that sort of thing.
Exactly. Those kinds of everyday activities become hard. And then the rash. It often appears on sun-exposed areas, face, neck, chest in a V sign, back and shoulders, the shawl sign, and over the elbows and knees. Patients might also have joint pain, fatigue, maybe a low-grade fever, general constitutional symptoms.
The notes mention some really specific skin signs. Can you walk us through those? They sound quite distinctive.
They are, yes, and they're really key for diagnosis. Firstly, the rash is often photosensitive, meaning it gets worse with sun exposure. The heliotrope rash is very characteristic. That's a bluey-purple discoloration, sometimes with swelling around the eyes, on the eyelids.
Heliotrope, like the flower.
Exactly, named for the color. Then you have Gottron's papules. These are raised, slightly roughened reddish or purplish bumps, specifically over the knuckles and sometimes elbows or knees. Very classic sign. You might also see something called mechanic's hands.
Mechanic's hands?
Yeah, it's where the skin on the palms and sides of the fingers becomes dry, thickened, scaly, with these sort of linear cracks. Looks a bit like the hands of someone who does heavy manual work. And finally, looking closely at the nail folds, you might see tiny, dilated blood vessels, nail fold capillary dilatation.
Wow, okay. Those are very specific visual clues. Are there other features beyond the skin and the proximal muscles?
Yes, definitely. The muscle weakness itself might be tender or it might not be. Some patients get Raynaud's phenomenon, fingers changing color in the cold. Importantly, the inflammation can affect other muscles too. Weakness of respiratory muscles can cause breathing problems, and involvement of the pharyngeal muscles can lead to difficulty swallowing, which is dysphagia or changes in the voice, dysphonia. There's also a significant risk of interstitial lung disease inflammation and scarring in the lung tissue itself. That's a serious complication.
Okay, lung involvement, swallowing issues. What about the patient's history? Anything else important?
Well, it affects both children and adults, so age isn't a complete differentiator. Asking about those systemic symptoms is key fever, joint pain, general malaise, unexplained weight loss. We also need to consider cardiac involvement. Things like conduction problems or even cardiomyopathy can occur, though perhaps less commonly. And gastrointestinal issues like ulcers or infections are possible, apparently more so in children, according to the notes.
So when you examine someone, what are the absolute must-checks?
You're really looking for those key signs. Carefully inspect the skin for the characteristic rashes, heliotrope, Gottron's, shawl sign. Check the nail folds for those dilated capillaries. And then a thorough neurological exam focusing on muscle power, specifically testing those proximal muscle groups, shoulder abduction, hip flexion, neck flexion. That pattern of weakness is crucial.
Okay, makes sense. So you suspect it based on the clinical picture. What investigations do you order?
Right, so confirming it needs tests. Blood tests are usually the first step. We look at muscle enzymes. Creatine kinase, CK, is often very high, sometimes thousands, but it can be normal, so it's not perfect. Other enzymes like AST, ALT, LDH, and aldolase can also be elevated due to muscle damage.
So elevated muscle enzymes, what else?
Autoantibodies are really important. An ANA, anti-nuclear antibody, is positive in about 80% of cases, but it's not specific. We look for more specific antibodies, the myositis-specific antibodies. The main ones mentioned are anti-Jo1, anti-SRP, and anti-My2. Anti-Jo1 is one of the anti-synthetase antibodies, found in maybe 30% or so. Finding specific antibodies can sometimes give clues about prognosis or risk of complications like lung disease.
Okay, antibodies. What about imaging?
MRI of the affected muscles can be useful. It can show inflammation, edema within the muscle. It's not always needed for diagnosis if the picture is clear, but it can help guide where to do a biopsy and sometimes monitor treatment response.
And EMG, electromyography.
EMG can help confirm if the weakness is due to a muscle problem, a myopathy, rather than a nerve problem. It shows characteristic changes in inflammatory myopathy. But, like CK, it can be normal in maybe 15% of patients. It can also help select the best muscle for biopsy.
Which brings us to muscle biopsy. Is that the gold standard?
It's often considered essential for confirming the diagnosis, especially if things aren't clear-cut. The biopsy allows us to actually see the inflammation and damage within the muscle tissue under the microscope. It shows characteristic features that differ slightly from, say, polymyositis.
Okay, so biopsy is key for confirmation. Once the diagnosis is made, how do we manage dermatomyositis? What's the approach?
Management is really focused on a few key goals: controlling the inflammation, improving the muscle strength, and managing the skin disease, and addressing any complications. Early treatment is generally thought to be better.
Right. What does that treatment involve?
Immunotherapy is the mainstay. Corticosteroids, usually high-dose oral prednisone initially, are the first-line treatment to quickly reduce inflammation. Topical steroids might be used for milder skin issues. Because high-dose steroids have side effects long-term, we often add a steroid-sparing immunosuppressant fairly early on. Things like azathioprine or methotrexate are common choices.
And if those don't work?
If the response isn't good enough, or for severe disease, other options like mycophenolate, cyclophosphamide, or even intravenous immunoglobulin IVI might be used. For resistant skin disease, biological agents like rituximab are sometimes considered. And patients with that anti-Jo1 antibody often seem to need longer-term immunosuppression. If there's lung involvement, that usually requires aggressive treatment, often combining corticosteroids with another immunosuppressant.
Okay, so mainly immunosuppression. Are there non-drug approaches too?
Absolutely. Lifestyle measures are important. Sun protection is crucial because of the photosensitivity, high SPF sunscreen, hats, protective clothing. Physical therapy is really important too. Controlled exercise helps to rebuild strength and prevent contractures, but it needs to be tailored, avoiding intense exercise during active inflammation. If dysphagia, the swallowing difficulty, is present, then assessment by a speech and language therapist is vital for safe swallowing strategies and dietary modifications. And of course, regular monitoring is key, checking CK levels, assessing strength, tracking symptoms to guide treatment adjustments.
Right, monitoring the response. What's the typical long-term outlook? The prognosis?
It's quite variable, unfortunately. It depends on the severity of muscle involvement, which organs are affected, the response to treatment, and importantly, whether there's an associated malignancy. That malignancy link significantly worsens the prognosis. Some people might go into remission, but many have a chronic course or a pattern of relapses and remissions over years. Only about 20–40% achieve a sustained remission off treatment.
So, not always a straightforward recovery.
No. And overall mortality is still higher than the general population. The main causes of death tend to be the cancer association, severe lung complications, cardiac issues, and infections, often related to the immunosuppressive treatment itself.
Are there specific things that predict a poorer outcome?
Yes, several factors are associated with a worse prognosis. Being older at diagnosis, male sex, non-Caucasian ethnicity. Also, a longer delay between symptoms starting and getting diagnosed seems to be negative. Definite cardiac involvement, significant dysphagia, having an associated malignancy, and testing positive for certain antibodies like the anti-155/140 antibody are all considered poor prognostic factors.
Okay, finally, let's recap the potential complications. We've touched on some already.
Right. So the big ones to be aware of are lung involvement, particularly the interstitial lung disease. Dysphagia, which carries risks of aspiration pneumonia and malnutrition. Calcinosis, these deposits of calcium under the skin or in muscles, which can be painful, ulcerate, and get infected. Mostly seen in juvenile dermatomyositis, but can occur in adults. And, as we've stressed, that increased risk of malignancy.
Any others?
Yes, GI ulceration can happen, potentially leading to bleeding or even bowel perforation. Cardiac issues like conduction defects, arrhythmias, or cardiomyopathy. Joint contractures can develop due to immobility and inflammation. And we also need to remember the complications from treatment itself, especially long-term steroids, things like osteoporosis, diabetes, cataracts, infections, and steroid-induced myopathy, which can sometimes confuse the picture.
Okay, quite a list to be mindful of. So to wrap it up then, dermatomyositis. It's that autoimmune condition hitting muscle and skin. Key features are the proximal muscle weakness, and those very characteristic rashes, heliotrope around the eyes, Gottrons on the knuckles. Always think about screening for underlying malignancy, especially in older adults. Investigations involve muscle enzymes, specific autoantibodies, maybe EMG and MRI, and often a muscle biopsy for confirmation. Management relies heavily on immunosuppression.
That's a great summary. Understanding that core picture, the rash, the weakness, the potential for systemic involvement like lung disease, and the cancer link is absolutely essential. It's rare, but you need to know it when you see it.
Well, hopefully this deep dive has given you a really solid, high-yield overview for your revision. And, perhaps something to think about further is that complex interplay. Just how do specific environmental triggers interact with genetic susceptibility to kick off these autoimmune processes? It's a fascinating area.
Absolutely. There's still a lot to learn there.
And if you do want to nail down this topic or revise other conditions in detail, don't forget to check out the resources at MSRA.com and FreemSRA.com. They're brilliant for focused revision. Thanks for joining us for this deep dive.